Okay, current procedural terminology. So the purpose, it is a uniform code where it is used for the billing and insurance purpose, and additionally data analysis like data science purpose they may use to make the research and to come to the conclusion how much of CPTs and what type of CPT is majoritarily used. So that is the main purpose. Usage, so this will be used especially for the outpatient because CPT is completely designed for the outpatient where they'll be used by the providers for submitting the claims. Maybe the different insurance companies will be using the codes to convert that into the payments. Okay, that is the main usage, and it is completely developed by American Medical Association. Their editorial board will be seeing little on the HIMA also because sometimes the CCS exam questions may come related to the AMA also, American Medical Association also. So we'll be seeing a little bit on the AMA. Then complementary to the ICD because I cannot just go with only the CPT because ICD is very, very mandatory. Why? Because if I wanted to go to the hospital, I need to have some disease, some condition, okay, some syndrome, some problem should be there, some signs and symptoms should be there. Then only I can go to the hospital. If I go to the hospital only, the next step you will be going for the some procedure. The procedure may be anything, okay. So they may take E&M procedures, or they may go for ED, or they may go for anesthesia surgery, depending on the specialty we go. But the main route is ICD. So without ICD, CPTs are not going to exist. Then the format. If you see the format for the CPT, it is a 5-digit numerical and it is a combined of alphanumerical also for the category 2 and category 3. Okay. So this format is the one which is given in the CPT book. Then coming for the next one. So simply a general idea about entire book, how and when it is getting revised and when it is getting added and how we are using the codes. Okay, here. So as I told, we do have more than now, it is more than 7,800 codes are available, CPT codes are available. It is always 5 characters. It is a numerical or alphanumerical. It has 3 categories. We'll be seeing each categories separately. Then, so every year once it will get revised. Okay, every year once, every January it will get revised. What are the revisions happens there? They may change the code description, or they may add the new CPTs, or they may delete the new old CPT and add the new CPT, or they may give the changes in the CPT description. Any one of these changes may occur in the CPT. Okay. Then apart from that, category 3. Okay, we have the category 3 course that we'll be discussing in detail about what is category 1, category 2, and category 3. Here we category 3, which is one more section in the CPT book that will be revised not only in the January, again in July also it will get revised because that is a temporary code, okay, or emergency code we call it as. That is the reason yearly twice it will get updated. Yeah. Then coming to the panel, who decides it? So this is what I'm talking about. Okay, so who decides this? Okay, as I told, the entire editorial board is American Medical Association. They are the editorial panel, which they will be doing the maintaining the book, revising the book, deleting the codes and adding the codes. Everything will be maintained by the American Medical Association. Every one to 4 years, they will be having the panel revisions, like how we have the elections every 5 years. Same way, they'll be having every 4 years, the entire committee will be changed. In the committee, there will be 17 members will be there. Okay, in the panel, there will be 17 members. Out of 17, 11 members are nominated by American Medical Association, where remaining 6 people will be nominated by Blue Cross or Blue Services or Center for Medicare and Medicaid. So that is BC and BCS and Center for Medicare and Medicare Services, that is CMS. Okay, then coming to the next one. In the book, we do have 3 categories. Okay, as I told, this entire CPT book is used for the purpose of outpatient, where it is again segregated or classified into 3 different categories: category 1, category 2, and category 3. Coming to the category 1, again, category 1 is subdivided into 6 different sections. Okay, so you can see the picture in the first section where it is completely going to be numerical codes, and it covers all the procedures and services performed in the hospital or in the medical practices. Okay, so as I told, this 6th section plays major role in the outpatient. Okay, so how we'll go by step by step. So when a patient is encountering some kind of signs and symptoms, initially he will visit to the evaluation and management. Okay, so in evaluation and management, we do have a different subsections where we'll be discussing on all these sections also separately. That is also very mandatory for the CCS exam. So separately we'll be seeing the guidelines and we'll be coming across all these things in the upcoming class. Okay, that will be the domain one. In the domain one, we'll be discussing in detail on the each sections. Okay, like CPC, we have separately based on this, but in CCS, it will include this also. Additionally, it includes the CPT related sections also, where we need to be good with that, because the questions are going to be asked related to this section. So as I told, you will be learning extra comparing to the other exams. You'll be learning extra in the CCS, so that we'll be covering in the future classes. Okay, so when the patient is going to the hospital with some signs and symptoms, he will be completely done with the evaluation management, and now he will be decided for two subspecialties. Okay, two sections will be decided. Either he will go for the pathology and laboratory for the blood test or urine test or for the diagnostic purpose, or he may go to the radiology department for the imaging purpose, for the diagnostic purpose. Now, based on the data, based on the information available in the both radiology and in the pathology, they may decide to come for two more sections. They may ask you to prescribe. They may give you the prescription of some medicine, and they may ask you to go for the medicine, should take the tablet or something like that, or they may ask you to go for the surgery. Okay, so from the evaluation management, you will be going for the pathology or to the radiology. From there, you will be decided to the two path, two subsection, that is surgery or medicine. If you go for the medicine, only this prescription of the medicine will be there. Where you go for the surgery, you will be going for some procedures. Okay, now before doing the surgery, or procedure, you will be given some sedation. That is the anesthesia section. So that is how this entire 6 sections are interrelated. So a patient who may start with the evolution management till the medicine he may end up, or somebody, they may come for the evolution management, they may end up with the medicine, or they may continue with the other subsections also. That is how this entire coding RCM works. Okay, that is how the entire coding will go. But we do, like if you see your ED coder, where you will be coding in the ED. In the ED, again, in the evolution management, we have the subsection where in that you will have critical care, ED, Profi, ED facility. Even in the E&M, we have E&M IP, E&M OP, in ICU, like a neonatal ICU, hospice services, and nursing services. Okay, so many subsections are there. Even it will go for, what is that? It may go for other treatment services and rehabilitation services, therapeutic services. So we can tell under the E&M only, all of the subsections are coming. Okay, even anesthesia, surgery, radiology, medicine, you can relate that everything is coming under the evaluation management, because evaluation and management will be the primary diagnostic or the primary like review of the system, where we'll be doing in the first section of the coding. Okay, so if you see the code range, can you see the code range which I provided here? So each subsection has the code range, where evaluation management always starts with the 99, whereas anesthesia always starts with the 00. Only few codes which is related to the moderate sedations were provided in that 99 series. Again, it is also used for the therapeutic purpose, which will come under the 99 series. Then we have the surgery, 10,000 series to 69,000 series. Then radiology. In the radiology, again, we have the three different sections. One is diagnostic radiology, then intervention radiology, then it goes for the oncological radiology. So in that, we have 7,000 series to 79,000 series. Then we will be discussing on the pathology and laboratory. In pathology and laboratory, we do have 15 plus subsections. Again, we have the so many subsections like specimen, surgery, okay, then laboratories, and we have chemical analysis and DNA analysis. So many subsections it may take you through. Then we have medicine. Medicine is something very general, where it covers all the non-invasive procedures like duplex, echogram, echo audiogram. Okay, so many therapeutic and as well as the diagnosis purpose related procedures or exams are seen in the medicine section. Okay, so these are all the overview of the category 1, where we'll be discussing in detail on each section in the category 1 in the upcoming classes. Okay, this is something to provide you some additional knowledge in the unlisted procedure codes. So each sections, wherever we came across, from the surgery sections to diagnostic radiology or intervention radiology, so all these procedure related, services related procedures may encounter the unlisted procedures. What is unlisted procedures? So there is so many procedures which are provided in the book. For whatever the procedures performed by the physicians in the hospital, we have the separate codes. Like there are so many codes, like there are so many services which is provided in the hospital. Unfortunately, all the services are could not be able to match with the CPT codes. Okay, wherever the services, okay, some of the services, some of the anatomical procedures where they're not able to perform the service, or anything new technology is going to be introduced for that service, they'll be keeping them in the unlisted code. Okay, those are the codes always ends with either 89 or 99. Okay,
Fine.
if you see one example, we do have the code for excision of ulcer. Okay, excision of pressure ulcer,
Yes.
anatomical site wise. Okay, certain site like buttock or certain site like vulva where we do not have the separate code. In that scenario, I should be going with the 15999 code as a unlisted code. Likewise, what are the procedures when I don't find the CPT code, when I don't have the CPT code in the CPT book, I need to go with the unlisted code in that particular section. Okay, that is the purpose of the unlisted code, which comes under the category 1.
Suppose
Category
small doubt. If
uh,
any anatomical site is mentioned and we are able to find it in the column,
mm.
so we will go with that particular code. So if we are not unable to find means we will go with unlisted procedure, right?
Yes, exactly. Okay.
Yes.
So it is like mostly, if you see most of the services, 99.9% of services will have the codes. Okay.
Okay.
Only rare cases, very rare cases where we go with the unlisted procedures. Okay. If you
Yes.
ask me, like when I'm coding almost like 2 to 3 years, when I was coding, even when I was doing for audit for 2 to 3 years, I might have coded one or two CPTs only. That's it. So
Okay.
lakhs of CPTs I've encountered. Okay, different specialties I've worked on: surgery, ED,
Okay.
diagnostic radiology, everything I worked on. So nowhere I will be having the chances to use unlisted
Mm.
code unless or until client is specifically asking us to use the unlisted codes. Okay.
Yes. Yes.
Apart from that, we have not encountered so many of codes. Then coming to the category 2 codes. So here it is a combination of alpha and numerical. Okay, so you can tell numerical and alpha. If you see F, okay, here F means you can keep it in the mind for your remembrance. You can keep it in the mind. F means information. Okay, additional information. Okay, or we can keep it in the mind like future. We can keep it in the mind like future. See, I will provide you a small example. Okay, so in this category 2 we have 9 different sections. What are the these codes are going to do means they are going to support the CPT 1, which is going to support the category 1 codes. These are called something we can call like add-on codes, we can tell. Okay, it is not
Okay.
exactly add-on codes, a kind of supporting code or add-on code, we can tell. Why? Because if I'm going to use only category 2 codes, there is no value for this, there is no payment for this. When I'm
Okay.
going to use category 2 codes, definitely I need category 1 code. Without category 1 code, I will not be able to use a category 2 code. This is a rule number 1. Okay. Second, to keep it in your mind, category 2, when I say category 2, you should remember future. Okay. It is a information or future, because in the information we have F, in future also we have F. For your remembrance, remembrance for associated study, we call it as. Sometimes these all things we may think we know, but we may forget. If you associate and study something, you will not be able to forget that. Okay, that is the reason I'm stressing and giving. Keep it in the mind. Category 2 means function, information or future, like that, which means they are going to provide a support for the category 1 code. I will tell you one small example, which is you might have came across. Okay, so if you see, I will take one example from the radiology, diagnostic radiology. So every year, if you see in the United States of America, females who have attended menopause, okay, post menopause, okay, after their 40s, they may encounter post menopause, which means like the entire periodical cycle will stop. What happens means because of this, when the periods are stopping for the females, the estrogen level which is maintaining in their body. See the role of estrogen, okay, the hormone which is present in the female body, which is secreted during the period. Okay, the precursor, the producer of the estrogen hormone is your periods. Okay, if there is no periods, you will encounter so much of problem. Now, what is the role of this estrogen hormone? This estrogen hormone has two roles. One will induce the bone growth. Okay, one side it will induce the bone growth, one side it will suppress the breast cancer. Okay, one side it will suppress the breast cancer. This is a main and important role for this estrogen hormone. Apart from that, there is so many roles is there. But in the females, after postmenopausal, most of the females you might have seen in our villages also, the grandmas, their body will bend over. The bone will not be
Yeah.
very strong. They'll be holding the stick and walking. And if you see in the United States of America, so many people, they go for the implantation, breast implantation. Because of the breast cancer, they'll go for so much of implantation. Okay, which means this estrogen hormones play the key role for this. Okay, when the estrogen hormone secretion is stopped, automatically you are going to encounter with either with the breast cancer or with the abnormal bone growth. Okay, to keep that in the control, the government, okay, the federal government, they have made a rule. Okay, they made a rule how we are applying the polio year for babies, how we are going for the diagnosis for the polio and all, right? So like that, they have a rule in their country where people who are attended menopause, they should be going for the screening mammogram. Otherwise, they have to go for, also they have to go for the DEXA. DEXA means bone density study. Two studies every year they have to go. That is a mandatory rule for them, and it is provided freely in the insurance. Okay. So here, when they do the screening mammogram, once the patient is attaining 45 age, automatically they are going to fall under screening mammogram. So when I'm coming for the screening mammogram, I will be in the normal. Say, for example, in the age of 40th, I'm attaining the postmenopausal. In the 41 age, they may ask me to take for the screening mammogram to diagnose whether I do have any problem, like I do have any symptoms or any conditions related to the breast cancer. Okay, to identify that, they may ask us to come. Now, this year you came, but what about next year? What about up next year? And if you have any problem, how I need to identify that? Just by doing the mammogram, I know I'm able to identify some problem, or I may come for the normal also in my result. Okay. But even if you're normal or if you're having some abnormality, how I'm going to identify that, how I'm going to follow up you. So for in that situation, you have something called reminder system. Okay. 7025F. It comes under, if you see the last one, structural measures is there, no? Under that, you will have 7025F. Okay. When I
Yes.
code as a coder, when I'm use 77067 mammogram code, along with that, I need to use 7025F code that will indicate the patient is a mammogram patient who has to come after 1 year for the same screening mammogram. Now, the 7025 is helping for the category 1 code. You're able to follow me? So this two
Yes.
category code is helping for the category 1 code to make sure that person is coming every year for the screening mammogram. Okay. Likewise, I have provided some examples here. Can you see? Diabetes care, hypertension, BMI documentation, tobacco use,
Yes.
cancer screening. See, if you see all these conditions, these are chronic conditions, long-term conditions. There is no treatment for them, only the controls we have. Okay. In our medical field, any condition in our medical field, we do not have any treatment. Okay. Only we have the control. Say, for example, if you're getting a fever today, once I take the paracetamol tablet, it doesn't mean like you are not going to be cured completely in the fever. Again, it will come after 2 months or 3 months, right? Any conditions, any condition, even it is a cancer, even it is related to the liver diseases or hormonal diseases or any disorders, once it is treated, you can keep them in the control. You cannot completely remove from your body. Okay, and these conditions where you can, it will be in your body, but you will not be able to see them visibly unless or until they are aggravating or they are giving some side effect. Example, diabetes. You see, we have the diabetes. We have a follow-up codes, category 2 codes, along with the diabetic codes, any services code if you're using means, or in the ED or E&M, sorry, not in the ED. In the E&M, if they identify the patient is a diabetic patient means they'll be going with these codes. Additionally, to make sure the patient is coming for the follow-up to do the diabetic care, like guys, hypertension, then BMI and tobacco use. People who are using tobacco use, they are very prone for the cancer, as well as they're prone for the AAA, abdominal aortic aneurysm. So for that, to make sure that person is having the counseling, or the patient is coming for the follow-up. So for all these things, we have the additional set of code that is a category 2 code. Okay. Next, going for the category 3 code, we can call this code as a temporary code. Okay. T for temporary. Okay. Remember like that. T for temporary. That is a category. Category 3. 3 stands for T. T stands for temporary. Remember like that. Okay. This is
Yes.
a alpha numerical. And what is the main purpose of this code means? They may use some emergency. Say, for example, in 2019, we got a COVID. If they're going to introduce some new procedures, after book is revised, you will not be able to do. That is the reason every July also it will get updated. So they may introduce new services, new procedures. Okay. That will be included in the category 3 code. And if any codes are in the research or if any codes for a new diagnosis purpose or any refinement have to be done in the codes, those all codes are kept under the category 3 codes, and those codes will have the 3 years of validity. After 3 years, they may come to the category 1. What happens? After 3 years, extremely sorry. After 5 years, they will come to the category 1. Okay, that is the main purpose of the category 3 code. We can call it as an emergency code, temporary code, okay, or a newly upcoming code or newly established code. Okay, any name we can call it as. To keep it in the mind, 3 means T stands for 3, category 3. So remember the code like that. Okay. Coming for the next one, a small attribute, whatever we discussed. Okay, so if you see category 1, category 2, category 3, it is all are going to the CPT codes. Only the purposes. One side, it is going to be for the procedure purpose, and category 2 for the quality tracking and measuring purpose. That is a temporary code. All are 5-digit, where it is a numerical, remaining are alpha-numerical, both are. Then reimbursement. So there is a reimbursement is the RVU value. Okay, relative value units will be different. Like we based on the category 1 only the payment will go, whereas the category 2 and 3 we do not have the separate payment. Okay, sometimes for the category 3 we have the payment, but not always. Okay, then locations, it is all 6 main body. And if you see like this category 2 is present after the category 2 codes, and category 3 is a separate appendix, which you will be seeing that also. Lifespan permanent in the category 1, whereas category 2 it will be ongoing and revised will be needed, where in the category 3 every 5 years it will get retired and it will come to the category 1. Either it will retire or it will come to the category 1. Usage managed for the billing, option with the category 1, and preferred over the unlisted for the data collections. Okay, as I told, that is a data collection codes only, which will be used in the different situation. Okay, these are the some of the attributes on the CPT category codes. So to make an our understanding, Bona, so I'm going in little slower phase only. Okay. So if you understand my speed, and if you're able to follow my speed and my language, my dialect, automatically when I take the classes, you'll be able to follow faster. Okay. So you'll go in the same phase so that it will be easy for you. Wherever you don't understand, please let me know. Okay. Coming for the book, in the book, you will be able to see the place of services. Okay. So some questions they may encounter based on the place of services. In that situation, the CPT book is going to help you. Here I have given some example, but we have almost 50 plus place of services. Okay. So if you see in the book, in the front page of the book, you will be able to see the place of services. Remember, place of services are available in the CPT book. During the exam, if you encounter any place of service related question, please come back here and review here. Okay. Then next is the symbols of the CPT. Symbols. So we have different symbols, revised, new codes, deleted codes. Okay. Then exemption codes, FDA approval codes, and add-on code. These all are the symbols which you'll be able to see in the CPT book. Okay. Before the CPT, like each CPT, you'll be able to see the symbol. Hope you might have came across those kind of symbols, right, Buna?
Yes.
Because if somebody like new means, I used to open the book and show to them. I hope you have seen it. If you're not seen it, let me know. I will show the symbols where it is also. Okay. Then in the book, additionally, what are the informations we have is like, so medical terms, procedural terms, okay, and the prefix, suffix, root. So we don't want to don't want to get confused, or don't want to be like, oh, where is this structure, or what is the term related to? See, it is like a ocean. We will not be able to learn all the medical terms, okay, but we have certain shortcuts. We have certain associated shortcuts where we can relate them and we can come to the conclusion. In that case, whatever the prefix and suffix and root for all the medical terminologies are available in the book itself. Please remember that. Apart from that, interestingly, you will be able to see the pictures of each and everything. See, anatomical illustration. So when any anatomical structure or anatomical terms you are coming across, if you don't know where this anatomical term is present, what is this anatomical term, you can come to the in front of the book and you can see which page the anatomical structure is present. You can go immediately to that place and you can identify what is the anatomical structure. Okay, as I told, even the doctors who are experienced 25 years, 50 years, they will not be very good with the anatomy. Okay, they will not be very strong with the anatomy. And what the anatomy we are learning is like 0.000001%, because the anatomy they learn is completely different. Okay, say for example, if you wanted to enlighten you, if I wanted to provide insight for you, say for example, you might have came across the term called scalp, right? You know where is a
Yes.
scalp? What is scalp? Any idea? Yes, top of your. But scalp means S stands for skin, C stands for connective tissue, and A stands for what is it? One structure is that I forgot that. Antostical. What is that? 1 second. I forgot that structure. Okay. Aponecrosis. Okay. Aponecrosis structure. Then L stands for loose connective tissue and P stands for peristonium. So what and why I'm trying to tell this means we usually think like, okay, scalp means okay, the outer cover of the skull, but the scalp has a separate meaning. Okay, that is how the anatomy, each and every place. If you go for the musculoskeletal system, if you go for the GI system, or if you go for integumentary system, and mostly if you see people who will not study about the lymphatic system. Lymphatic system is the one of the very, very important and mandatory system across all 11 system, but we don't prefer that. We always go for the cardiac system, circulatory system, or we go for the digestive system. Otherwise, you'll go for the musculoskeletal system. More than this all system, lymphatic system is very, very important. Okay. So why I'm trying to tell this means anatomy is something very vast. Okay. Even if you're going to be 50 years as a doctor also, we will not be come to know so much of things. As one example, as I told, till now we know scalp means, okay, scalp means something outer coverage. But scalp has its own meaning. As I told, skin, S stands for skin, C stands for connective tissue, and A stands for aponecrosis, and L stands for loose connective tissue, and P stands for peristonium, okay, or cranium also we can tell. Okay, so that is the entire meaning, that much of depth we have. Again, it goes inside. In that also, again, the layers, connective tissue layer. In that loose alveolar connective tissue layer is there. Okay, like that it will go deeper. But what we learn is scalp is the outer cover. Okay, so such a situation, if you encounter any terms if you don't know, you can come to this anatomical illustration and you can identify the codes. The books which you have, CPT book, PCS book, and ICD book will have entire anatomy. Okay, entire anatomies are available inside that. We have to use them wisely. In the CPT book, in each section, you will have the pictures separated for the anatomy. Okay, got my point? So that is the reason I'm stressing this. Then next one is format of the terminologies, family code. So we might have encountered the codes, right? If you see, the codes can be segregated into two major classification. One is the parent code, the second is the intent code. Otherwise, we can call it as a child code also, parent code. Any group of codes, okay, you can see here, right? 25100, arthrotomy, wrist joint with biopsy. So that is the main code. Next, 25105. How I have to study this means that is an intent code. How I'm going to study this means arthrotomy, wrist joint, that semicolon which will distinguish each code. So I should be reading as arthrotomy, wrist joint with the synovectomy. So I have separate code for arthrotomy with the synovectomy. I have separate code for arthrotomy with the biopsy. So 25100 is a parental code and 25105 is the intended code or child code. See, there is one more example also I provided here. Radiological exam. Just single view, 2 view, 3 view, 4 view. 2 view, 3 view, 4 views are the intended code or child code. The main code is parental code. This is how I need to read. This is how I need to understand the format of the terminologies in the CPT code. We are good? We're able to follow me, Buna, here?
Yes.
Want you to provide any more example? We are good, right?
Yes.
Okay, so you might have encountered even in the ED, like when it comes for the straightforward, low, then moderate, high. So the description is only the last area it will get changed, right? So likewise, after the semicolon, entire descriptions are going to get changed. Okay, so here next one is like what is standalone code? Okay, and what is add-on code? Standalone code means where the code will not have any further family, and we'll have the separate building further. Can you see this? The first one which I provided as example in the excision, that is IND, incision and the drainage. So I have one code where it is completely related to the acne surgery. But next to code, we have the set of code where it says simple and single and complicated and multiple for the incision, drainage of abscess, okay, in certain areas. So likewise, family code, see phenolial cyst. In phenolial cyst, simple cyst and complicated cyst, two set of codes we have. Same way, foreign body removal, simple or complicated. So those are the family codes, and which have only one code, we call it as the standalone code. Okay, that is the meaning for the standalone code. Then CPT sequencing. Okay, when it comes for the CPT sequencing, we always go with the RVU value, that is relative value unit. So the relative value unit means So something it is paid for the physician based on this unit only. And this unit is compromised with work RUV, practice expense RUV, and malpractice RUV. These three combined together, we call it as RVU value. So the higher RVU value, the primary code we are going to use. Okay, that is how the sequencing will go. So if you see here, 10040 and 10121, these two codes are in this section, in the incision and drainage section. So which is going to be the primary code, which is the need to be sequenced first, even though they are going to come in the same sequence of codes, same subsection, which is going to be code primary. In what basis I will be able to decide? Key see down 0.73 for 10120 and 0.62 for 10040. Even though the 10040 is coming as a in hierarchy wise, it is coming as a primary hierarchy, but the RVU value is more for 10121. So I'll be coding 1021 as the primary CPT. Okay, that is what the sequencing are decided by. In the exam point of view, we no need to be worried about this because you're not going to get any sequence related for this. Okay, so to understand the book, I'm giving you in detail all these things. Then, so you might have encountered something called headers. Okay, so in any section, if you see something in the black color, that we call it a section. Below that, something will be in the light green color, that is a subsection, and below that you have called heading. Below that we have the subheading. Section, subsection. So 6 sections are there. That is a surgery section, radiology section, or anesthesia section. That are the sections. And a subsection. In the E&M is a section. ED is a subsection. Okay, E&M is a section. ED is a subsection. Under the ED, you may encounter, if you see for critical care, again we'll go for emergency care, okay, urgent care, something we may go for separate headings, okay. In that we'll go for inpatient, outpatient, like that we may go for the subheadings. And next to that, what is the exact procedure they are going to perform? That becomes a subheading. So here we may have the guidelines for the section, we may have the guidelines for the subsection, we may have the guidelines for the heading, or we may have the guidelines for the subheading also. So try to remember, these are the structure of the headers, whichever is present in the CPT book. Next, guidelines. So we do have 3 set of guidelines. One is parenthetical guidelines, then specific guidelines, and general guidelines. Parenthetical guidelines, below the CPT, you may encounter something do not code combined with, okay, you can see in that section, this section, like that it will give you some guidance. That is called parenthetical guidelines. And the second one is like specific guidelines. Okay, any subsection, can you see it is not subsection, heading, any heading for the subheading will have the separate guidelines. So we saw here, right, the pink color, that heading. For the heading you may have under the surgery, under that for the heading you have some guidelines. Those are called specific guidelines. For the specific subheading you will have the heading guidelines which need to be followed for that particular heading. Okay, then third is the general, complete for entire surgery section or entire E&M section or for entire radiology section. You have some sort of guidelines. Those are called general guidelines. Okay, use all 3 when applicable, but if you're able to use only one, always go to the highest ranking guideline. Okay, so we can use all 3, but which is closely related, which is highestly related to the procedures that need to be followed as the primary guidelines. So parenthetical guidelines, specific guidelines, then general guidelines. Then coming to the next one, the book is again divided majorly into two sections. Okay, I can tell like 2 divisions, we can tell, because 6 sections is there. We don't want to confuse with the term. We can tell this as 2 important divisions. Okay, one is tabular section, the other one is the index section. So we know what is the tabular section. Okay, so tabular section and index section, it has their own purpose. Okay, in the index section, where you will be able to see completely to possible to locate the range of codes by using the terms. Okay, any main terms or any what is that, any important terms or any index terms. Okay, by using those terms you will be able to identify that particular section in the index page. Okay, through the index page only you will be going to the tabular section. So we can think like index page is something like a summary of the entire table. Okay, so where by using the terms, so in a say for example, I have the example also. We'll discuss that example. So if you say for example, one I provided a laparoscopy surgery, cholecystectomy, direct to. So what it happens when I see under the laparoscopy, okay, it may take you to the. I can search in the surgery, or I can search in the laparoscopy, or I can search in the cholecystectomy. When I search that, it will take me to the range of codes. Okay, it will tell you from this range to this range. From that, I need to go back to the tabular column. In the tabular column, whichever is very precisely, it is like whether it is a simple or complicated or one view or two view or three view, whichever is specifically related to my documentation, that I need to take. Okay, that is a major difference for the index and tabular. Index, it will take you to the, by using the subterms or main terms or cross reference terms, it will take you to the that range of codes. Once you know the range of codes, from there I will be going to the tabular column, where for the in the tabular column I do have the separate sections for separate table, CPT range, where I will be taking the codes from the tabular column as a final code. Okay, that is a key differences. Okay, for these two divisions in the book, one is index and the other one is a table. Okay, without seeing the index, I cannot go to the table. But since we are experienced people, sometimes we may go directly to the table. So people who are newly working using the book, definitely they have to go for the index page. Then appendixes. Okay, appendix, what it does means it will provide you summary for whatever the information, wide range of information available in the different part of the category 1 and category 2 and category 3. Okay, it is like a compiled information. So if you see related to the appendix A, it will give you the description of the modifier. In the book, beginning of the book, in the first page, okay, in the left side of the book, you will have the modifier. You will have only description of that modifier, but that usage of modifier, okay, the availability and usage of modifier, you'll be able to see in the appendix A. Likewise, for each and everything, okay, each and everything which you are coming across in the codes, across the codes, whatever the information you are seeing, for them we have the summaries. Okay, sometimes there will be resequencing codes where I will not be, say for example 1 2 3 4 5 is coming, means I will be able to identify the codes. Okay, even though I'm seeing an index page, I may not be able to root back in the tabular column properly. In that scenario, if I go to the section B, appendix B, there I will be able to identify whichever the resequenced code, whichever addition code, whichever the deletion code directly. Okay, directly I'll be able to identify. Like that, you will have the crosswalk for the deleted codes and resequencing summary code. See, appendix M and appendix M. When I don't know the section of the code, series of the codes, sometimes people will feel that difficult. 1 2 3 4 it is coming means fine. Suddenly 3 and 4 is missing means we may think where is this code? That will be in the option. In that scenario, if you're not able to search email, most will be there in the previous page or next page. Mostly it is like before two page or after two page, the resequencing will be there. Rare cases, you may not be able to identify which may go for the different sequencing area. In that scenario, if I come to the appendix M and if I see the resequencing codes, I will be able to identify that. Okay, that is the main purpose of this appendix. Okay, so just this is nothing. I think already you know. So read the documentation, identify the key terms in the book. Then third is like I need to go for the index page in the CPT range. From the CPT range, I need to come for the tabular section. So I may have the description of the codes. I should read the description of the code. Then I need to use or apply required modifier. Finally, I need to append the codes. Finally, check for the pair rules and append the codes. Okay, these are the 6 steps for the identifying and routing the codes in the CPT book. Okay, so this is a general introduction on the book. Okay, we'll move to the next set of the book where I'll be covering on the ICD and I'll be taking you to the guidelines like domain one also. I will be covering you simultaneously in that. Okay, so far we are good, Buna. You're able to follow me, right? Buna, you're there? Hello. Yes, Buna, we are good so far. Okay, let me go for the next one. Next, we will be discussing an ICD. So here in the ICD, these guidelines are little mandatory one. Okay, you need to be little careful on these guidelines. So which is very, very important for the exam as well. Okay. So let's share the screen. Able to see the screen now? No?
Yes, yes.
Okay. So we are going to discuss about ICD, International Classification of Disease. Okay. So here a small introduction. Again, this is used for the addressing the disease and tracking the health records. Okay. And for the primarily, it is used for primary and the secondary and tertiary care. Okay. So if it is see, this entire ICD is something like a standardized code, which is used for to addressing the diagnosis, okay, conditions and disease conditions. To address them, this ICD is used, and this stands for what the book we are using is like International Classification of Disease, 10th revision, clinical modification. What we are using is clinical modification. Is different cause ICD-10. PCS is different. ICD-10 CM is completely different. Okay, we'll be discussing PCS after completing the CM. Okay. And this is completely maintained by WHO, World Healthcare Organization. The main purpose is to track the disease condition, the emerging and the what is it? Most increasing diseases. Okay, most conditions which are preferably coming to the patients. Okay, those are the conditions they will be tracking out. Okay, it will provide you 7 benefits. Very importantly, 7 benefits it's going to provide: specific coding precisions. Then it will use as enhancing data analysis and a global coding standard it has. Then granular medical capturing means each sections like what we can tell like signs and symptoms separate sections, HCD separate section, and cancer separate section, endocrine system. So like that we have separate sections. Okay, that is what granular medical capturing. Then is the accurate patient diagnosis. So whatever the condition he is having, that can be addressed with the ICD codes. Then improve the reimbursement based on ICDs. The payment will be increased. Then public health surveillance. So that will keep a track which is most like exceeding and most existing conditions across the world. Okay, how they are able to track the COVID condition, the 2019 and 20, which is contagion years, which has been made the people to quarantine. They're able to track each and every place, every conditions in every area and every places by using the help of ICD-10 in different countries. Okay, so as I told, the purpose is like it will transform the documentation into the numerical and alpha numerical designation for the diseases, injuries. Sometimes it is for the procedures also. That is what PCS we are relating to. Okay, and the same time it has been grouped. Like as I told, it is grouped for different anatomical system as well as the purpose as well as the external causes. Likewise, it has been segregated in different groups. So based on the groups only, we'll be able to take the codes. Okay, that is a small introduction on the ICD-10. And then a small history we are going to see. So it was started during the 1853. Okay, mainly it is used for the purpose of tracking the people death. Okay, so how many people are dying. Okay, then it got improvised like how many people are dying because of what disease, whether it is a contagious disease or it is a natural disease or because of snake bite or animal bite. Like that, to keep the track, they started using this step by step. They grouped into different classes. They made a different list of the codes. Okay, and they segregated as index and what is that? Separately, they segregated as then tabular list. Likewise, one by one, it got improvised till ICD-9. It was a numerical, but when it came to the ICD-10, it became a alpha-numerical. Okay, now in future we are going to get ICD-11 also. It started in 2015 itself, but still it is in work under process. It is keep on getting improvised. Maybe like 2 or 3 years, we may encounter ICD-11 also, with the gap whichever need to be filled will be filled with the ICD-11 codes. Okay, this is a small history on the ICD-10. Then how we are going to take the codes. Okay, these are the main 3 steps. Okay, so first step is like I'm going to search the alphabetic index. Okay, main terms in the alphabetic index. Through that I'm going to search, which means like, say for example, person is coming for the fever or headache. Okay, that is a main term that I need to search in the index page. Okay, so one main thumb rule is there in the book. I should not search by the anatomical side. I cannot go and search the kidney, heart, eyes. I cannot do that. In the ICD-10, I need to search by based on the what are the signs or conditions or disorders or external causes the patient is coming for. Okay, that will be the main term which I need to search in the index book. Okay, by using the index book. From the index book, I may end up with the 3-digit code or 4-digit code or 5 decimal code. Okay. Then by using that code, I need to see the complete code in the tabular list. So tabular list will provide me the complete verification and guidelines. Okay. So many guidelines will be coming across in the tabular column and in the index column, index page. So those guidelines are very, very mandatory. Based on the guidelines, we'll be using the codes in the ICD-10. Okay, that is the main purpose of the ICD-10. That is how we are going to use the ICD book also. Search in the index term. In the index page, we have to search for the main terms. From the main terms, we have to we have to see the tabular list for the complete description. And there in the description, you'll be able to see the guidelines. Based on the guidelines, we are going to use the codes. Then coming into the brief notes on sections and brief notes on guidelines which we are going to follow. Okay, if you see, there are 4 important sections in the book. Okay, in ICD book, and 1 appendix column. If you see this 1 and 4, which is completely related to the outpatient, but these 5 sections are related to the inpatient, which is very, very important for the CCS exam. Okay, which will be followed in the CCS exam. This is the domain 1. Okay, the domain 1 which you are going to cover in the second phase, that is partially related here. 60 to 70% it will cover here itself. So we have a very huge class for the ICDs. Just a minute. So here we have huge sections to discuss. Okay, I think more than 100 plus slides will be there. It may take 1 or 2 classes also. We'll discuss as good as possible. Okay, so as I told, 4 important sections in the book. Okay, again, as I told, it is included for the domain 1 in the CCS. So if you see the first section, which will be talking about conventions, general guidelines, then it will be talking about the chapter specific guidelines. So we'll be discussing on the conventions also, general guidelines and chapter specific guidelines. Then section 2, it will tell you, see, non-outpatient setting, which means it is equal to the inpatient. Okay, for the inpatient, how the principal diagnosis are considered, how the additional diagnosis are considered. Okay, those will be able to see in the section 2 and section 3. When come for the section 4, we will be discussing about how the diagnostic coding and reporting guidelines for the outpatients. Again, it is coming for the outpatient, how we are seeing for the prior principal diagnosis, additional diagnosis for the inpatient. Same way, we'll be using it for the outpatient, the guidelines. Then third one is the present on admission, which is very, very important for the CCS. For doing IPDRG also, that is very, very important. Like equal to the IPDRG, we are going to discuss so many topics which are related to the IPDRG also. Okay, in future, if you wanted for IPDRG also, where you can utilize these guidelines completely. Okay, so as I said, this is going to be little vast, which is included for the domain 1 also, some part of the domain 2 also. Okay, both are included here. So where you can see this section, can you see which I have highlighted here? Okay, see the first section in the book itself, second section, third section, fourth section, and appendix. Everything is there in the front page. Okay, in the content page of the book, you can be able to see. See, I'm not asking you to rotate the book. When you see these pictures, you can be able to understand in the book, these all things will be there. Okay, so I'm making you as easy you can be able to understand. Because if I ask you to open the book, if I tell that, especially when you are sitting in the online, it is going to be very difficult task for you. In the same time, that should stand in your brain. Okay, which if it is in a picture format, that will be in your brain. So try to remember this picture so that you can address in the book very easily. Why I'm telling this all importantly means, yes, when you're coding, you may not have encountered these all things repeatedly. In the rare case, you may encounter. But in the exam, you should be very good with understanding the book. If you know where and which place that particular section is present, the guidelines is present, then I can rotate very faster. Otherwise, I need to spend some time in searching. That 4 hours is a very precious time for me. When it becomes very precious time, each and every minute is important for me. I cannot waste that. Okay, I will tell you in the future how to manage the time and all. Okay, in that scenario, if I keep on rotating the page, it is not 1 page or 2 page. ICD alone, it is having 1,100 page. CPT alone, it is having 1,000 page. Okay, and ICPIX was like, so not ICPIX you are not going to use. CPS, PCS alone, it is having 1,000 plus page. In that situation, if you keep on rotating, our time is waste, right? So how I can mitigate, how I can manage the time? If I know where and what and why it is all present, automatically I'll be able to do it. Okay, now we are going to discuss in detail about the section 1. In the section 1, we are going to discuss about the conventions. So conventions. So these all are the guidelines in the conventions. So there are almost 19 plus guidelines in the conventions that we are going to discuss one by one. Okay. The first is index versus tabular list. What is the key difference? Like a CPT in ICD also, we do have the index as well as for the tabular list for the ICD. Okay. So if you see here, so few informations also I have it. So this is the book. So in the book, you will be able to see the index page through the alphabetic words, alphabetic of the conditions. You will be able to pointing out the codes. Okay, from the term, so you can go for the main term. From the main term, you can go for subterm. From the subterm, you will be able to come for the some set of code. Okay, but that is not a final code. Okay, keep that in the mind. Index codes are not final code. Few codes will be there. Even that I will be indicating to you in the future slides, which are the codes you can consider that as a final code, which are the codes will not be considered the final code. Even though you consider that as a final code, Abuna, we need to always go back and check in the tabular list. Okay, we need to verify in the tabular list for the additional guidelines. Okay, those guidelines we'll be discussing in the further slides. Okay, tabular list. A tabular list, again, it is going to be completely numerical. Okay, alphanumerical, where you'll be able to see the codes, complete codes, like a third digit, fourth digit, fifth digit, sixth, until the seventh digit, you will be able to see them. Okay, again, in the index is again classified into three different sections. Okay, three important sections. Those are, first is like index to disease and injuries. Okay, those will be in the gray color. Can you see that gray color in the book? It will be indicated in the gray color. Then there is a drug table for the drug and chemical, which will be indicated in the violet color. And the external cause codes, it will be indicated in the orange color. Okay, so these are the three subsections in the index. Okay, that index section will have the three subsection. Those are available in the first part of the book. And the second part of the book is a tabular list, where you will be having one more additional there, pathophysiology, about any disease condition. If you don't know about any disease condition, almost all disease conditions informations are available in the book. Okay, where it is available in the tabular list. When you see some disease condition, if you don't know what is the disease, you can go back and verify in the tabular list in each section, for A section, B section, C, D, like that. For each, whatever the conditions are coming, those conditions pathophysiologies are available in the tabular list. Okay, like something, any new information you gathered, or everything is older here?
Older only, sir.
Sorry?
Yeah, little bit I know, sir.
Okay, so this pathophysiology you used to refer in the book?
Yes, sir.
Okay, fine. So it is in the tabular list, it is available. We can verify the code, and specificity of the code, the accuracy of the code is always available in the tabular list. Okay.
Yes.
Then, see, one important thing is, like, if you're good with the ICD, whatever the specialty it is, you can able to manage. Okay. The big problem with us is, like, when I am a ED specialty, when I am a diagnostic radiology specialty, I'll be focusing on my CPTs alone. No, it is completely wrong. As I told, CPT is going to, as we discussed, CPT is going to be complementary for ICD. So if I'm good with the ICD, if I'm good with the disease conditions, pathophysiology, if I know the pathophysiology of the disease conditions, whatever section it is going to be, you'll be able to handle it. Okay. So if you see across these 6 specialties, the most widely the ICD is used in the diagnostic radiology. The second highest it is used in the surgery. Remaining and all, like whenever the need is there, that is the places we are using the ICD. Otherwise, so many projects we are not using the ICD itself. Mandal, we are not building based on the ICDs. Most of the softwares where it is picking the ICD automatically, but that becoming the malpractice, that is the root. It is making so many automations now. Because of that only, it is becoming automated, because we're not spending so much of time in that. And now everything is coming under the AA, and we are losing the jobs. So people are not understanding ICD is something which we need to be good with. If you're good with the ICD, whatever the specialty it is going to be, we'll be able to handle. Even it is going to be a HCC or IPDRG, even for the clinical documentation investigation also, they were widely using the ICD. So we should be good with the ICDs. Okay. So this is a format of the structure of the ICDs, where first 3 will be telling you the categories, and remaining 4 will be the subcategory, and the last will be like, so remaining 3 will be the subcategory, the last will be like we can call it as a qualifier or details or extension, we can tell. In PCS, we call it in different name, and in the ICD we call it in the different name. Okay, so the
Yes, sir.
category it will be always alphanumerical. So always it will be alpha, where character 2 and character 3 will be numerical. 4, 5, 6, 7 will be alpha numerical. Okay, and seventh will be
Yes.
always extended. It will provide you the additional information. Okay,
Yes.
we learned ICD the way if you tell any disease condition, we'll be able to take first 4 digits. By keeping that 4 digit, we'll be able to come to conclusion. Okay, say for example, S is for injury means M is for related to the musculoskeleton, J is related
Yes.
to the respiratory system. Like that, we will be able to understand. Then if you see for S after S, if it is 0, it is coming means head. S1 means it is for what is it? It will come for face. S2 means neck. S3 means chest. S3 means abdomen. Like that we used to go. Then S3, 1 means it is for superficial injury, 2 means fracture, 3 means dislocation, 4 means hemorrhage or contusion. Like that, we will be able to take the condition till the 3rd digit to the 4th digit. When it comes for the 4th digit, precisely we'll be able to identify which anatomical structure it is, in that which anatomical area it is, or what is the etiology of that condition. We'll be able to identify. So from the fracture, in the fracture, we'll have different set of fracture, right? A dislocated fracture, sorry, displaced fracture, non-displaced fracture. Again, in the displaced fracture, green stick fracture, or transverse fracture, oblique fracture. Like that, we will have a different etiology that we will be able to identify in the 4th digit. And 5th digit, anatomical structure, where it is a little finger or proximal region or distal region or medial region or lateral region. Like that, we will be able to identify. The last, it will tell you the severity or the laterality. Severity in the sense, it may give you like whether it is a right side or left side, or it is a little finger or it is a index finger. Like that information you will be able to get. The last extension, or we can call it as qualifier also, that will give you the whether the patient is coming for the first time or second time or long time. Like that information you will be able to get with the that extension or with the qualifier digit. Okay, this is the format where you will provide you the information completely related to the ICD. If you're good at understanding the structure, you any sections you will be able to take 4th to 5th digit of the code. So we used to code till also. Now also, if you tell me some conditions, I'll be able to tell what is the first, second, third, and 4th digit of the code, because we understood how the category, how the etiology and anatomy and site are addressed with the this category of code. That is how the format and the structure of ICD 10C. Then coming for the next one, some more detail on the tabular list. Okay, in the tabular list, so from the index, okay, from the index we may end up with a 3 digit or 4 digit like that. From there, it will take you to the 3rd category, 4th category, sorry, 4th, 3rd characters, 4th characters, or 6th or 7th characters, which will be addressed in the tabular list. Can you see here? When you see something in the
Yes, sir.
red color indication in the tabular list, that is going to tell you need to check for the 5th character. In the 5th character, when you see the red color, it will tell you you have to search for the 6th character.
60
When you see in the
characters.
6th character red color, it will ask you to go for the 7th character.
7.
Okay, that is the indication. Same way, if you see here in the left side, one picture I have given, if you see something ending with the 7th character directly, in between we need to use placeholders. Okay, that we'll be discussing in the upcoming slides. Okay, so first 3
Okay.
characters 08. In middle we have to use the placeholders. Then last character it is going to be 7th character we are supposed to use. Okay, so even the characters, what is the 7th character will be indicated in the same subsection itself, where you can able to see A for initial, D for subsequent, and S for sequela. Like that you will be able to see in the tabular list for the category, subcategory, and for the last and specificity of the codes. Okay, that is how the structure works in the tabular list. Okay, so remember, red is the indication we need to go further, blue is the indication we need to stop. Then coming to the placeholder. What is placeholder? Placeholder is a gap filling. Okay, wherever the full codes or specificity codes are missing, I need to use the X as a placeholder to fill
Yes,
the
sir.
gap. It may start with the 4th character, 5th character, and the 6th character. You can see the example where M80.9, 5th character and 6th character, which we have used X character as a placeholders. Okay, in future expansion that will be used for. Then coming for the next one, discussing on the 7th character. Okay, mostly the 7th characters are used in the chapter 15, chapter 19, 13. Okay, and this if you see, and sometimes it is in the chapter 7 also. Okay, each chapter has its own purpose, where in the 15th chapter it is indicating the outcome of the deliver and the fetal presentation, where in the 19th chapter it is telling you the what type of encounter, initial or subsequent or sequel encounter. In the chapter 13, it is giving you the stages of the kidney failures. Okay, now recently it is got updated in the 2025, it is got updated, and the chapter 7 it will give you whether it is going to be the lateral right side or left side. Okay, that indication will be provided with the seventh character. Okay, so what seventh character will do, it will provide the specificity, like specific details of that particular chapter. Okay, that information, what is the seventh character, it can be from A, B, C, D, G, S, K, H, G also it may go. Sometime it will end up with the A, D, S also. Always it will be ending with the blue color. Remember that. That is the use of the seventh character in the tabular list. Okay, then
Yes.
you are going to encounter two important terms in the abbreviations of NEC and NOS. Okay, not elsewhere classified, not otherwise specified. Otherwise, we can call it also other codes, or we can call it as a unspecified codes. Okay, now what is NEC? What is NOC? How it is used in the index page? How it is used in the tabular list? Both we are going to see. Generally, NEC means other codes, which means not elsewhere classified. Here, doctor is not listing in the ICD, which means the patient is having some disease. Okay, the patient is having the disease here. Doctor is not listing it. Okay, that is the reason it is not elsewhere classified. If you see the other one, doctor is not specifically telling. Okay, so here how we can correlate means the doctor is, say for example, we have different type of fever. If I take fever means there are n number of fever is there. One good example, if you want to tell migraine, okay, migraine, cluster migraine, intractable migraine, there are so many types of migraine is there. Okay, see, if some migraine is listed, say for example, X migraine is listed by the doctor, but that is not available in the book. That is not available in the book. Other things are there. A migraine is there, B migraine is there, C migraine is there, D migraine is there. But X migraine is not there. He's telling some type of migraine. That X migraine is not there means it is other specified. That is what? Not elsewhere classifiable. So doctor is telling, but book is not, furtherly it is not able to classifiable. Okay, that is what? Not elsewhere classifiable. And we can tell it as other code. What we can tell it as? Other specified code also we can tell. Otherwise we can tell as other code. Then unspecified. Migraine is there. A migraine, B migraine, C migraine, D migraine, X migraine. This many type of migraine is there, but doctor is not documenting that. See here, doctor was not specified. Okay, he knows it is migraine, but what type of migraine? When the doctor is not specifically documenting that, even though there is a list of conditions are there, list of migraines are there, when doctor is not listing it out, that is called not otherwise specified. This is all because of the doctor is not specifying it. Even though it is listed, is not specifying. When it's not specifying, I'm going to take unspecified code. Okay, you got the point? So that is other specified and unspecified stands for. Now, slight changes will be there for the tabular list and index page that we are going to see. So if you see here, what you are seeing is in the index page. In the index page, so you can be able to see NEC, the structure which will be addressing NOC. Both you will be able to see here. That will tell you like whether the codes which is ending with the 89 or 8 or 09, that will give you the indication in the index page itself. Those are coming under NEC category or NOC category. If you see here, NEC category, say for example, diphtheria. Okay, in the index page, they provided diphtheria. There are so many types of diphtheria is there. But doctor is specifically documenting bull neck diphtheria. There is no bull neck diphtheria in the list. In that scenario, I need to take the specified site, which means specified site I need to take. Based on that, I will be ending up with A36.89 as a code. Next, if you see one more example here, can you see the headache? Okay, in the headache also, there are different type of headache is there. When it's not addressing any specific type of headache, there also it is going to end with the code, NEC code. Okay, there also it is going to end with the NEC code, which is like not elsewhere classified. Fusion is not classifying it further. So in that situation, I need to go further, other elsewhere specified code. Same way in the tabular list also you can be able to see the difference here. So in NEC, in the alphabetic index, okay, we are looking into the NEC in alphabetic index. The alphabetic index represent the other specified. When the specific code is not available in the condition, index directly to the other specified code. But in the tabular list, small difference will be there. Same other specified, when the specific code is not available for the condition, tabular list includes other condition, which is like under coding, identify the condition for the other specified codes. So it will give you the description for that particular condition. Say for example, if you see the down, there you are seeing bronchitis 09, right? 98.09. Okay. If you see the down, when I say other, so say for example, the patient is a bronchitis disease and it is addressed for bronchitis fibrinoid. Here in bolus, chronic bolus is there, specified bolus is there. Okay, bronchitis bolus is there. Bolus in chronic is there, and bolus in specified is there. But there is no bolus fibrinoid is not there. Fibrinoid is not there. In that situation, I need to go for the specified code. What is the specified code? J98.09 stands for. What J98.0 stands for means what are the other conditions are there that will be listed here. That is a major difference. In the index page, that condition will not be listed. Okay, say for example, bull neck diphtheria is not listed, but in the tabular list for that specified code, you will be getting there what are the other terms. What are the other terms used for that condition? Okay, here the terms will be provided. Can you see here J98.09 bronchitis is a classification of bronchitis, stenosis of the bronchitis, then tracheobronchial collapse, ulcer of the bronchitis. For all this condition, I can use one code. Okay, that is what they're addressing here. Okay, so this is what a NEC difference. Okay, NEC difference where it will be there in the index and tabular. In index, I will go for directly other specific code. But when I see the same code in the tabular list, I'll be having the description for that conditions also. Okay. So it is like bull neck diphtheria, it is not available in the index, but if I see in the tabular list, I will be able to see bull neck diphtheria under the NEC condition. Okay. Then coming for NOC, always NOC is going to end with the 9. So NEC, it is ending with the 0, 9, 8 and 8, 9. Here it is going to end with the 9. Here also you see, doctor is not specifically telling what type of headache. I'm going to use the unspecified headache. Okay. But what is that unspecified headache? What is the description of that unspecified headache is available in the tabular list. Can you see here? Same M51.9, it says facial pain. Can you see? NOS. Facial pain, NOS, which means not otherwise specified by the physician. Okay. So even though it is not specified in the index, when you come for the tabular list, you can see what is the other terms given for that headache is also available here. Okay. That is a major difference between the alphabetic index and the tabular list for the NOS. Okay. Then coming for the next one, some of the symbols you will be able to encounter. One is a parenthesis in the appendix and the tabular list. Okay. Parenthesis in the appendix, we can tell like a supplementary word, alternative words. Okay. Other words also we can tell. Okay. If you see here, hypertension, you can call it as essential hypertension or idiopathic hypertension or malignant hypertension or systemic hypertension. Whatever it is going to be the same hypertension only. Okay. Same time, the same parenthesis symbol in the tabular list. What is the purpose? Okay. Same here also it is going to give you the supplementary words. There is no big change for the alphabetic index and in the tabular list for the parenthesis. When it comes for the brackets, slight change will be there. In the index, it will tell you what is the manifestation code and what is the etiology code, which is should be used as a primary code and which should be used as a secondary code. That indication will be there in the index page itself for the bracket. Say for example, if you see here, they are given polyneuropathy amyloid. Polyneuropathy amyloid E85.1 in bracket they have provided G63. Here, which should be coded manifestation code and which should be coded as the etiology code. Here the manifestation is code it is going to be will be present in the bracket. Can you see G63? Yes, manifestation code. Okay. So in that scenario, that manifestation code. So I need to go back and see in the description of the CPT that will be not CPT, description of the ICD where that will indicate which code should be used as the primary code. Okay. And which code should be used as the additional code or secondary code detail will be provided. So when you see the bracket, I need to go and see in the tabular list. Same bracket, if it is given in the tabular list, it will give the abbreviation. Okay. Alternative synonyms. One good example, E. coli. E. coli means Escherichia coli. To indicate the abbreviation of that particular synonyms that will be placed in the bracket. So that is the difference between the tabular index and the alphabetic index and the tabular list for the bracket. Okay, here it will tell you the what is the manifestation code, that it will give you the synonyms for that particular phrase or particular This is a particular wordings. Okay. Then semicolon, sorry, colon. So colon, it will tell you some description it will give you. Okay. So incomplete terms which need one or more modifier following the colon to make it assignable to the given category. So the colon is there means it will tell along with the primary code, you need to use some additional code. Okay, some information. The colon always here, the colon is going to tell if you're going to use this C08 at any cost, along with that, you should be using any one of the listed codes. Okay, that is what use additional code to identify, that is indicated with the colon. Okay, so remember that. Then next is like shared guidelines in the book. One line will be the shared line. Okay, so that will be like a indicator for you. Okay, under the embolism you get air, under the air you get following, under the following you get the abortion. Okay, that is we call it as shaded guidelines. Okay, so we need to go with that side and shaded guidelines. Always people will confuse, so they will not be able to follow that line. Even in the ICD10.com or Codify, you will be getting these lines. Okay, so this is our
Yes.
line purposes. We need to use the line properly. The next one is a additional character. Any ICD ending with a tick mark, which will tell you you need to go for the tabular list for the additional character. I told you, right? So
Yes.
some codes which may not have the tick mark, that will indicate that is the end of the code. Okay, but wherever you can see the tick, that will tell you go and see in the tabular list.
Yes.
Okay? So here if you see 09 by 09, you do not have any tick mark. That is the end of the code, but we need to check what is the guidelines is there for that in the tabular list. When you see X97 with the tick mark, I need to go further and see what is the last code for that. Okay, like next character, fourth character, fifth character, seventh character, till where it is coming, I need to verify in the tabular list. Next one is the use of small and big end. Okay, it is not a big difference is there. If you see here, previously in the ICD-9 and all, we used to code each condition separately. So say for example here, they provided A18.0 title tuberculosis of the bone and joints. Previously we used to code like tuberculosis of the bone, tuberculosis of the joint, separately. Now we have the combinedly a code. This combination is done because of the term called and. Okay, by using the word and, we are able to do that. Can you see here one example I provided? Sorry. An example I provided here, occlusion and stenosis. Occlusion
Yes.
and stenosis,
Yes.
both are almost similar only. Occlusion and stenosis are almost similar. Okay, so they do not have much difference. Any idea what is the difference between, sorry, any idea what is the difference between occlusion and stenosis?
Narrow.
Okay, what is stenosis then?
The same meaning. Just
Sorry.
narrowing. Narrowing only, sir.
Okay, see, nothing. Okay, if you see, stenosis is a narrowing. Okay, it happens because in the blood vessel, the narrowing happens because of the plague. Okay, we call it some kind of sedimentations will be there in the blood vessel. We call it as a plague. Now it will restrict the blood flow. When it comes for the occlusion, same plague but 100% closed. Okay, it will stop the flow completely. Stenosis, restriction of the flow, where occlusion completely block the flow.
Okay. Yes.
Okay, which means stenosis will have the percentage 20%, 30%, 40%, 50%. Some percentage we can address for the stenosis. For occlusion, there is no percentage. The entire tube is closed. Remember the O is closing entirely. That is what occlusion. That is the difference between occlusion and stenosis. That is the reason they given combinedly the same codes. Okay. So combined code. I do not have occlusion in cerebral artery and I do not have separate code for stenosis in cerebral artery. Both I have the same code. Okay. That is the purpose of and here. Okay. Then coming for the next one, inclusion terms and inclusion notes. Okay, so very importantly, inclusion terms and inclusion note. So what is inclusion term? Okay, so inclusion term means any CPT, okay, under the fourth or fifth or sixth category, character, there will be a specific description. Along with that description, we can tell like this. Your team lead, say for example, your team lead name is X. We can call it as brother. We can call it call him as a team lead, or we can call him as X. Like that, we will have the inclusion terms. Okay, which means a condition will have the certain name. So here is a good example I provided. If you see type 2 diabetes mellitus with diabetic nephropathy, that is a description for E11.21. Okay. For other condition like a glomerulonephrosis, intracapillary glomerulonephrosis, Clemston-Wilson disease, for that also the code is same. Okay. So if you see, it seems to be 4 different conditions, but the code is one. Seems to be 4 different conditions, but the ICD is one, which means those are included conditions only, one and the same conditions only. Okay, the pathophysiology of this condition is same, where I'm calling it as in different way. I'm calling it in a different way. It is like one house with a different address. Okay. So for my address, my brother address, my mother address, everybody have to come to my house only. Same here. Inclusion terms will give you the different description for the one ICD. Included notes. Okay. Included notes. See here. Bacterial pneumonia not elsewhere classified. Okay. Includes. What it includes means bronchopneumonia due to bacteria other than S pneumonia and H influenza. Which means when I use J15.0 or J15.1, okay, I have specifically, I don't want to search separately for other condition like pneumonia, S pneumonia or H influenza. Those are inclusive terms for the J15. So I don't want to go for the separate codes for them, which is already included in that J15 category itself. Okay. This note appears immediately under the 3-character codes title to further define or give example of content of the category. Okay. Here for Epsilon pneumonia, I have a separate code. Pseudomonas, I have the separate code. But if the documentation is telling about S pneumonia or influenza separately, I don't want to go for separate code. I can go with the J15.0 or J15.9 directly. That is what included notes it will be indicating for you. Okay.
Yes.
Then exclude 1 and exclude 2. Very simple. Exclude 1, do not code combinedly. Exclude 2, where you can code the combinedly 2 ICD. Okay. So if you see some exceptional cases there, here that only I need to address for the experienced person. Okay. So once again.
Yes.
Okay, fine. I thought that was missing. Okay. So here, say for example, any conditions, okay, any condition which is related to the same conditions or it is happening in the same site. Okay, in that situation, like we can tell like they are mutually exclusive conditions. Okay, here I given the emphysema. Under emphysema, so many types of emphysema is there, where I cannot code J43 along with J98.3 or J98.2. Okay, that is what completely excludes. Okay, so do not code here, do not combine and code here because they are one and the same. One and the same. When it comes for the excludes 2, they are similar but not same. They are similar but not same. Or we can tell like because of that, because of this that happened. So one good example we can think is like what is it? Sinusitis, chronic sinusitis and acute sinusitis you can code together. Okay, that's what like we feel like sinusitis is the same condition. Whether after acute it might have converted to the chronic. Yes, because of acute only it became the chronic, but still we consider acute as well as the chronic, which means not code here. You also have diagnosis littered in the coding level. Okay, so here we need to verify whether it is at exclude 2 or 1. Exclude 1, definitely I will not be coding. Exclude 2, I can be coded along with that if it is documented. That is also very, very important. If it is documented, I can be able to code them as well. Okay.
Yes.
Then, if you see some cases where I need to code both, one critical exception is there for exclude 1. See here, for example, if the patient is, one example I given, there are, to my knowledge, I have for 10 to 15 is there, one I have added here. If a patient having a both psychogenic dysmenorrhea and sleep-related teeth grinding, this can be coded together even though and exclude one note existing because 2 conditions are unrelated to
each other.
Okay, because yes, sleeping is completely different. And dysmenorrhea is completely different. But why? Because of the what is that? What is that section? Because of the 5th chapter, the guidelines says like that. Okay, based on that guidelines, it is coming under the exclude 1. Yes, so we can tell like pathophysiologically it is related, but anatomically it is not related. Okay, so that is what some exceptions will be there. Not all. Some exceptions will be there where we can able to code them also. Okay, so here, as I told, both are coming the exclude 1. Both are different conditions. That is what main thing we need to monitor here. Okay, so this is the difference between exclude 1 and exclude 2. So exclude 1, do not code. Exclude 2 can be coded if the diagnosis is documented. Then coming for next guideline, that is etiology and manifestation. Etiology means what? Manifestation means what? So very simple. If you see, Etiology is something, the primary disease condition. Because of the primary disease, whatever the other side effects, we cannot kill side effects, complications, or because of that one more disease is arised. Okay, because of that one more disease is arised means we call that as an manifestation. If you see one good example, if you wanted to tell you, dementia and Alzheimer's. Dementia and Alzheimer's. Both are same or different? Both are not same. Both are little different. Why? Because dementia is a major condition. Because of dementia, you may end up with the Alzheimer's. Okay. One type of dementia is the Alzheimer. Okay. The dementia will induce you the Alzheimer. That is the reason if you see here. So we have to code the etiology primary. Followed by that, we have to code the manifestation. So if you see here, first code first underlying physiological condition. So when the patient is coming for the dementia with the Alzheimer disease, okay, if the patient is coming with the dementia and Alzheimer disease, I will be coding the Alzheimer followed by the dementia. If you see the both F02 and G31, both the places you will be having the indication telling you code first, use additional condition. Here, when I'm using the G31, I need to go for the additional condition. See here, let me take the cursor. See here, F02 series will be coming here. So I need to use additional condition when I'm using the G31. But when I'm using F02, I need to use code first as the G series as a code first condition. Okay, so both are, it is like etiology and manifestation. If you see, diabetes is the etiology. Nephropathy or neuropathy, okay, or intracapular glomerulonecrosis, these all are the manifestation. So because of the diabetes, you are getting that condition. So when you see the under the diabetes, when you see, they may ask you to use additional condition, okay, under the diabetes. When you see the, what is that, necrosis, under the necrosis, they may tell you code first condition as the diabetes. Okay, that is what the etiology and manifestation. Etiology is the code first, use additional code. In addition, classify whatever the conditions are coming under the manifestation need to be coded. Okay, so for mostly it will not be able to see in the index page, where in the index page you will be able to see the bracket which we saw, right? Through the bracket you will be able to see, but we have to come to the tabular list for the conclusion whether it is additional code or first code. Okay, that is the guidelines on the etiology and manifestation. Then coming for other set of guidelines with C also, code also. You might have encountered all this already, I think, Boonam. Okay, even though
Yes, sir.
just refreshing everything because that is a foundation course. So when you come for the exam, these are little mandatory. Okay, with means very simple. You can lead in the code with, by, due to. Okay, so those all be coming under those conditions. All will be, you can be listed an index page itself, so that it will lead you to the next level of codes. Then C, when they say C means you do not have the separate code, we have to go back into the C, that particular place wherever it is telling. I need to go to the main term and search through that main term. That is the use of C. When it comes for the C also, it is like I can see here also. If it is not listed here, I can go and see in the one more main term, that is a C also. It is not like necessarily I have to see there. C also means this code also, if I lead whatever the code I'm getting, same set of code I will be getting in the C also. Sometimes the anatomical structures won't be there. There I have to go. Then code also. So code also, which is like along with the primary code, I need to complete, to make sure to ensure that the entire ICD is fulfilling. I need to use the code also. If you see one example here given, speech and language development delay due to the hearing loss. Yes, sir. Yes, for 80.4 I will code. What type of hearing loss? That I need to mention. That is a due to hearing loss. What type of hearing loss? That is the reason I need to use the code also condition. Okay, additional one more, which is a two codes, twin codes we can tell. Then default code. Default code is nothing. Whatever you're getting in the documentation, that code should be coded. So whatever the doctor is documented in the alphabetic index, whatever you are getting, that code need to be. That is what. Without a tick mark is there. Can you see? These are all codes. There is no tick mark. That's the default code. Still, as I told, even though it is a default code also, I need to go and search in the tabular list whether any there or not. Okay, so these are straight codes only. There is no bracket, no parenthesis, or something like I need to go for includes or excludes, and not much is there. Yet still I need to go back and verify in the tabular list. Okay, then symbols. Can you see the symbols down? Okay, so these are the symbols you'll be able to see in the ICD book. In the bottom of the book, you will be see that. So we can call it as a symbols or indicator. It will give you the additional input for that, whatever the ICDs are, whatever the codes you are going to use during the coding. Okay, just information for you. Then coming for the age conflict symbol, so we have a certain symbols which will be indicating the what is the age range, and that range will tell you whether that code should be used for this documentation or not. Okay, there's a newborn or pediatric, maternity or adult. There will be symbols in front of the ICDs. I cannot like misuse. Say for example, mostly for this infant P series codes, there will get these confusions. Okay, some of the conditions where you will not have the codes direct code for the newborns. In that situation, we may end up with using the adult code. Okay, to avoid that, there will be indication will be there. Only those set of codes will be used for the based on the age criteria. Okay, now this sex conflict symbols that is removed now completely. Previously, it used to be there. Male and female symbols used to be indicated. Now that symbol is completely removed, so we need not to be worried much. Then additional character requirements, which you have seen already, the tick mark if it is indicated means we need fourth, fifth, and sixth character. That is all the additional character requirement symbol in the index page. Then other symbols, okay, manifestation and key terms, macro codes, other specified codes, unspecified codes. Okay, these are you'll be able to see the terms in the book. Okay, so manifestation go in front of the code itself, like in the tabular list itself, they'll be telling it is a manifestation code, or this is a macro code, or other specified codes or unspecified codes that will be indicated in different colors. You'll be able to see that. You need to get alert. Apart from that, first listed code, first appear code, second appear, second semester code, third semester code, new codes, new text, revised code, and a revised text. These all are the symbols you'll be able to see in the book itself. And again, tip definitions also available in the tabular list, not in the index page. Then other symbols, whichever we have seen in the previous slide, right? So those symbols and purpose, why I'm telling this all symbols means if you're a HCC coder, high risk coder, or if you're going to be IPDRG coder, you may end up with the symbol, CC symbol, POA symbol, PC, MCC symbol, and by keeping these symbols, you may come to the answers. You may get a questions related to the CC and MCC, okay, major complication and comorbidity, or complication or comorbidity questions you may get. So we have the list. So many list is there. Okay, some conditions are categorized as the major complication and comorbidity, and some conditions are categorized under complication or comorbidity conditions. You may encounter the questions in the exam. In that scenario, if you know the ICD for, say for example, is coming for pneumothorax, you don't know whether the pneumothorax is CC or MCC. You don't know that. What I'm supposed to do? In that scenario, if I go in the tabular list, if I see the ICD for what is that, pneumothorax is J98.11, right? So if I go and see that code, okay, in the tabular list, inside the tabular list, in front of that code, it will be MCC or CC. So you can easily come to the conclusion, okay, pneumothorax is a CC, or pneumonia is a MCC. You can come to the conclusion. Based on that, you can arrive the code. So when we are discussing CC and MCC, I'll be discussing in detail. That is a domain 1. We'll be discussing in elaboration for what is comorbidity and complication, and major complication and comorbidity in detail there. Okay, so the symbols will help you. So that is one of the reason I added those symbols also here. We can utilize a symbol even for POA. Can you see POA symbol, POI symbols will provided. Sometimes presence on admission conditions. All conditions will not come in the POA. Certain conditions only will come. If you're not clear about that, we can go to the ICD book, and in the ICD book you can search that particular condition code, and we can come to the tabular list and finalize whether it is a POI, whether it is a CC or MCC very easily. Okay. Then code first, use additional code also. We already seen all these things. Okay. So code first, it will ask you to code first that condition, followed by that, whatever the etiology should be primary, then followed by the manifestation. Use additional also same like that only. It is not compulsory. If it is required, we are supposed to use, which you will be seeing in the tabular list. Code also is compulsory, where along with the primary code, you have to use the secondary code also. Exclude to include, exclude and exclude to. These are some of the descriptions which you'll be able to see in the tabular list. Okay. Then coming to the next one, that is second section. Okay, what we are seeing so far is like index and tabular list in the what is it? Conventions, code guide, general and coding guidelines. In that, in the index, we are seeing the second section here. In the second section, we have tabular and drug chemicals. These are, it is going to be, there are two tables, drug and chemical table, and one more is a neoplasm table. So both it will address you. It will address you completely on the drug and chemicals, and it will address you completely on the neoplasm, where you can read it in the book also, but this table will specify what type of cancer it is, whether it is a malignant or secondary, calcium in situ, benign, uncertain behavior, or unspecified behavior, whatever the category it is coming, whatever the condition it is coming, you will be able to see. So primary is the cancer where it is originated. Second is the cancer where it has been distributed. Carcinoma in situ means where the where the cancer is started, but it is not spreading. It is going to spread. Okay, that area is called carcinoma in situ. Benign means it is a cancer, it will not spread at all. Uncertain behavior means we don't know whether it is a mass or cancer or it is a lump or it is a malignant or non-malignant. We don't know what is the behavior. That is the uncertain behavior. Unspecified behavior means I don't know whether it is a cancer or not, but something it is growing. The uncontrolled growth is there, the uncontrolled development is there. So it is an unspecified behavior. If you come for the drug table, it is categorized into 6 important categories. Okay, one is a poison accidentally or unintentionally, and poisoning intentionally, or somebody is poisoning you, that is assault. We do not know, okay, whether it is a poison or not, undetermined, and we will not be able to determine it. That is what the undetermination of the poison. Then adverse effect and underdose. Adverse effect means after using some drug, you get some kind of problem, that is an adverse effect. One more is like underdose, which is something I need to use more. When I don't use more, it goes for the underdosing. One example, if you want to give one underdosing means, say for example, morphine for painkiller. If I give the correct level, only my pain will be controlled. If I don't give correct level, it will induce the pain and it will increase the pain. That becomes the underdosing. Okay? So these are the 2 tables you will be encountering in the ICD-10. Then coming for the revision of the section. Okay, so completely, if you see, these all of the sections we have seen, starting from the format structure and placeholders, 7th characters, includes, excludes. Somewhere I've added repeatedly with the description also for excludes and see also all those things. Okay, so these are the completely we are discussed in the section 1 conventions. Okay, so tomorrow we will discuss on the next section, that is general coding guidelines. Okay, so that will give you what are the general guidelines which are following in the section 1. Okay, so tomorrow we'll continue the remaining classes. Okay. So far you're good, right? So you're able to follow. So I think this is something you already know. That is the reason you are able to correlate and follow. Maybe from PCS tomorrow, when we start the PCS, once we completed PCS, I think we will be able to start by Tuesday, I think. Okay, because go for 2 more classes also, maybe 3 classes also. That time, so in that scenario, if you don't understand anything, let me know. And this is going to be new for you also. So we'll discuss that in detail. As I told, this is something you are preparing not only for the inpatient, you are preparing for both outpatient and as well as the inpatient. So mostly I used to suggest most of the people go for the CCS exam. Why? Because we can learn more. And what is the market status is like, you might have encountered like different places you might have encountered, like NCOED also, I think. What they will do is like they will teach you the question. Okay.
Yes.
You will not provide additional knowledge. People who are preparing for CCS or CPC exam, please try to refer this, because we do not question paper. Okay. Okay, Bona, we'll continue tomorrow.
Yes, sir.
Okay, thank you, Bona.
Thank you, sir. Thank you, sir. Sir,
Yes, Bona.
any recordings available for today class, sir?
Recording is there, Bona. I will share you the recording. Okay.
Okay, sir. Okay, sir.
Fine.
Thank you so much.
Thank you.
Yes, bye, sir.